Please can you present your findings?
This is Mr. Turner. Mr. Turner has had a video-assisted thoracoscopic surgery. The physical signs are 3 scars on the left chest wall, including a 10 cm transverse incision on the lateral chest. Indications for his VATS procedure may have included a wedge resection or segmentectomy, a lobectomy, decortication, a bullectomy, or treatment of recurrent pneumothoraces.
Are there any benefits of video-assisted thoracoscopic surgery over open thoracotomy?
Because VATS procedure involves a smaller incision than an open thoracotomy, there is reduced pain, reduced wound complications, reduced healing time, and reduced length of stay.
What are the possible indications for a lobectomy?
The main indication for a lobectomy would be lung cancer. Other indications would include an aspergilloma, TB, a lung abscess.
How would you investigate a patient that had a suspected lung cancer after taking a history examination and performing a chest radiograph?
Having taken the history and examination and performed a radiograph, my next investigation would be a staging CT of the thorax, abdomen and pelvis. Having undertaken this, I would want to get a tissue diagnosis. This may involve a bronchoscopy and direct sampling, a bronchoscopy in EBUS, or potentially CT-guided biopsy. Having undertaken these investigations, if there was a potentially curative option for this patient, I would want to do functional imaging with a PET-CT before working up the patient for surgery.
How might you work up a patient for surgery, i.e. assess their potential fitness for surgery?
Aside from a full history and examination, important investigations would include full lung function tests, including transfer factor assessment. It would also be important to send the patient for cardiopulmonary exercise testing.
If you were to be performing a lobectomy in a patient, what FEV1 would you want the patient to have?
To have a good chance of a good outcome from a lobectomy, I would hope that the patient has an FEV1 of at least 1.5.
And for a pneumonectomy?
For a full pneumonectomy, I would want the patient to have an FEV1 of at least 2.
Do you know of a VO2 max threshold which offers a better post-operative prognosis for the patient?
In order to hope to have a good prognosis after the operation, I would want the patient to have a VO2 max of at least 15 mils per kilo per minute.
Tell me about the different histological cell types of lung cancer.
Lung cancer can be broadly classified into 2 groups. Small cell lung cancer, which accounts for approximately 20% of presentations, and non-small cell lung cancer. Non-small cell lung cancer can be divided into adenocarcinomas and squamous cell carcinomas, which together make up the majority of pathologies, alongside large cell carcinoma and neuroendocrine tumours.
How do the treatment options differ for small cell and non-small cell lung cancers?
Small cell lung cancer is a very rapidly progressive disease and tends to present late. It's therefore rarely something you can operate on and treat surgically. The treatment is therefore for early disease, or what was previously known as limited disease, normally chemoradiotherapy, and for late disease, often palliative chemotherapy. For non-small cell lung cancer, the treatment may include curative surgical treatment. Other treatment that may be added adjuvantly or in isolation would be chemoradiotherapy.
Thank you very much.
Thank you.